you. Good afternoon, everybody. Welcome to the July meeting of the Derby Health and Wellbeing Board. Nice to see so many people here, some faces I haven't seen for a while, certainly not in this context. So yes, it's good to see people here. I'm aware that some people do find this format a bit formal. Unfortunately, I don't believe we as a council have a meeting room where it's sufficiently large for potential numbers of people to attend, and I will declare an interest is that I sometimes can't hear people in those meeting rooms. So just to remind everybody, if you want to speak here, obviously you need to press the button to turn on the mic, and then when you stop speaking, if you could turn it off as well, please. I'll try to remember to do the same as well. Thank you. Do we have any apologies? I've got Paul Heselgrave, Councillor Paul Heselgrave.
I'll add him to the list. I've got Michelle Arrowsmith, Denise Baker, Chris, but he's here, I believe, for the first hour. Yeah. Helen Dilliston is covering him. Gino Di Stefano, Lee Sharrard is covering. James Joyce, Jenny Watson is covering. Clive Stanbrook, Sam Dennis, and Stephen Hansley. And that's all.
Thank you, Lindsay. I mean, we have added quite a few extra councillors to the list of members of the Health and Wellbeing Board, not to sort of outnumber the rest of the members, but mainly because there are various interests that would seem very relevant for them being on the board. I know that Councillor Paul Heselgrave, since he agreed to join this, has become the deputy leader, and in that capacity he's having to cover for someone else, but I know he's quite keen to attend the Health and Wellbeing Board. I'm very pleased that we've got 2 councillors here, but it is a shame that the others who are keen to join are not here. That's just a little dig from me, but there you go. Thank you, Lindsay. We don't have any light items. Are there any declarations of interest? No, thank you very much. Are we all happy to accept the minutes of the 9th of May as an accurate record of that meeting? Yes, thank you very much. So our first item today is one from Robin Dewis, Director of Public Health here in Derby, and it's an update on the Derby and Derbyshire Health Protection Strategy. And then are you just going to run into item 6 as well, Robin, which is an update, a themed update from that board? Thank you very much.
Thank you. So, yes, I'm going to talk first of all around an update on the health protection strategy. And just to say, I am aware that there was an appendix that should have come. And apologies, that was the summary, the plan on the page, but that is within the slides. So hopefully it should all be clear as we talk through. And if you remember, we did have the health protection strategy here a couple of meetings ago. So next slide, Lindsay, thanks. So I'm going to just do a brief summary of the strategy and then an update on the progress against the strategy, some of the key points from the Health Protection Board, which is the next item, and then there's a couple of other items related to health protection just to mention at the end. So the Health Protection Strategy is owned by the Health Protection Board, and just a reminder that the Health Protection Board is a board that sits across the city and the county and reports to both of the Health and Wellbeing Boards. And the purpose of that board is to provide assurance to both directors of public health around the health protection system across Derby and Derbyshire. And so the strategy was developed, and it's just here a summary of the vision and the key objectives. And the design of the vision and the objectives is very much so that this strategy links into and sits alongside the other strategies that we have as a system. So the vision being about working in partnership and protecting the population, and then also from the objective perspective, thinking about how this fits into the areas of the integrated care strategy around start well, stay well, age well and die well as well. So ensuring that it's coherent to the other strategies that we also have. Next slide, thank you. And this is the main item around the strategy, which is those 3 areas of preventing, preparing and responding. but as I mentioned, also the assurance as well around the system. So the strategy is there to build that assurance, to make sure that there is that visibility across the system as to what's happening, and considering a broad range of health protection areas. So, and just to summarise what we have there: infection prevention and control, antimicrobial resistance, communicable disease, vaccination and immunisation, screening, emergency preparedness, environmental health aspects, including air quality and sexual health as well. So those areas are all considered within the health protection strategy. And through that, there were 6 areas of focus identified. So the next slide, oh, already there, thank you. So first of all, thinking about what the enablers will be, and part of the conversation that we had in the development of the strategy was that we work within a really complicated system. There's been considerable change over the last 10 to 15 years across that system. And it's still trying to build the relationships, the reporting, the visibility of all of this work. So thinking about communication and coordination, the roles and the responsibilities, and the organisations involved within this have changed since 2012, 2013, when we originally brought the responsibilities for health protection with us. The workforce, and particularly that expertise, the knowledge within the workforce, which there's been a considerable loss around that. The data surveillance and intelligence, and the challenges we have around sharing that between different organisations. Governance within a complex system, how we work together, and fundamentally how we have a strengths-based approach in our tackling health protection issues. Next slide. So the 6 areas of focus were the areas that were chosen as priorities for the initial part of the strategy. So the first areas for us to focus on. And there were 2 of the enablers that were chosen from that, which were around communication and coordination and roles and responsibilities. And those 2 areas really indicating the work that we're trying to do to understand the system within which we work. So when we entered into the pandemic, the system looked slightly different, and as we came out, we'd got the establishment of the UK Health Security Agency, but also different expertise that had been developed across the local area. From a delivery perspective, these 4 areas were chosen to be the key areas of priority for us to start with our focus. So community infection prevention and control, and particularly thinking across community settings for that. Vaccination uptake, both in children and adults, but also in thinking about the inequality in that uptake. Thinking particularly around the risks for vulnerable populations, and thinking within that, we're thinking about groups that weren't covered elsewhere. So 2 examples there being migrant groups and also care home residents. And then finally, the 6th one, strengthening our preparation and response in relation to environmental hazards and emergency events. So that includes pandemics, but also extreme weather and other responses. Next slide, thank you. So what I'm going to run through is just some of the progress that we have been making in all of these areas. And once I've run through the progress with the strategy, it'd be really good to take any questions around where we've got to with that. So from an enabler perspective, this was the issue around communication, coordination, roles and responsibilities. And as I said, just noting actually that the system has become increasingly complex. And part of the work that we're doing is making sure that we're building relationships between the Health Protection Board and other key boards and organisations. So we've been looking to strengthen the links with the board, with the Integrated Care Board, and particularly establishing some regular updates through to the Population Health and Strategic Commissioning Committee within the ICB. Building our links with the Local Health Resilience Partnership, which is part of the emergency planning response, and my colleague Ellie in the county is a co-chair of the LHRP, and we now have a member of the LHRP on the Health Protection Board to ensure that we have that relationship between the two, but also that we receive reports there and updates around the LHRP meetings. And from a UK Health Security Agency perspective, we have membership on the board, and they have a key participation in the agenda as well. Also to note that there's been some work regionally with the Directors of Public Health across the East Midlands in developing a community improvement. So this is where key members of the public health teams across the East Midlands can come together to discuss and share their work on health protection. And they've developed an assurance framework, which is for all of us to use within local areas, really to try to standardise the way that each area are approaching the assurance for the Directors of Public Health that the Health Protection Boards provide. So that's one of the key documents that we're using to drive the work of the Health Protection Board. Next slide, thanks. From a community infection prevention and control perspective, I think it's just an acknowledgement that, and I think we learnt this particularly during COVID, it was really clear, but people that use health services, people that work in health services, it's a continuum for all of us between our exposures within the community and our exposures within NHS settings. And what we have across Derby and Derbyshire is a historic issue that became evident during the changes of 2012-2013, where there was a loss of that commissioning of some infection prevention control services across community settings. So we have, for example, care homes who the UK Health Security Agency have a statutory responsibility to provide advice for them around any outbreaks, but we don't have a service that provides any of that proactive support that we found so valuable during the pandemic. And that's been one of those areas that we've been working on together to identify a solution really to cover that. During this work, we've also been building relationships with the System Assurance Group, the IPSAG, to ensure that NHS-focused system IPC group has stronger links into the Health Protection Board and we communicate more effectively. And just to say as well, we have been running a pilot through the public health team here in the city, funded through some of our COVID funds that we received, which is around some proactive work with care homes. So the team at UHDB have been undertaking proactive audits, training and follow-up audits with the care homes in the city. It's been offered to all, and 58 of the homes have taken part. And in all of those homes, when they undertook this work, there were areas of improvement identified. And there's just some examples there of what comes up, as you might imagine. Some of the bare below the elbow practices, some of the issues around mattresses, cleaning, sharps compliance. And then some of the really specialist functions that some care homes undertake, such as enteral feeding. All of those areas really benefiting from an audit approach and an oversight from a specialist team. And they've been able to deliver some bespoke training and also provide some standardised tools for the care homes to use to audit their own practice. And they're currently in year 2 of that work and are re-auditing and have managed around half of the homes. And you'll see 18 out of the 23 have shown some definite improvement in that re-audit. So we're waiting for an evaluation report to be completed for that, which I would be really keen to bring here for information. But I think it's shown some real benefit of some of that proactive work in the community and what that can do with a very small resource. Thank you, Lynn. Next slide. So the next area was vaccination. And when I was looking at this, I think I'd lost sight, I think, of how many vaccines we have and how many different programmes there are actually. So when we think of the routine programmes, we've got the preschool ones, which are the babies, the 8, 12 and 16 week programme. There's another vaccination schedule at a year, and then another one at 3 years and 4 months just before the starting of school. There's also 2 programmes that run for school-aged children, which are delivered by the School-Aged Immunisation Service, and that's the only place that these programmes are delivered. There's programmes for pregnant women, and then we also have programmes for older people, some for over 65s and one now for over 75s as well. And there's just a list there of the conditions that we offer vaccination against. I'm just going to run through because it was, when I listed it, it was quite pointed really. So diphtheria, tetanus, polio, pertussis, which is whooping cough, Hib, which is Haemophilus, which is a cause of, can cause pneumonia, can cause meningitis, hepatitis B, meningitis B, rotavirus, which is diarrhea and sickness virus, pneumococcus, which is a cause of pneumonia, meningitis C, measles, mumps, rubella, influenza, HPV, which is the human papillomavirus, which is the cervical cancer vaccine, meningitis A, C, W, and Y, shingles, COVID, and the new one that's just being introduced is respiratory syncytial virus. And just to the next slide, please, Linz. I just wanted to show a few slides on what's happening with vaccination performance. So I've just picked some of the different programmes at different ages. This is the vaccination that's that sits in those early 8, 12, 16 weeks and is reported at the age of 1. So these are the children that have received that required vaccination by the time they get to the age of 1. And the years along the bottom run from 2010 to 2023. That pink line is England, the light green line is the East Midlands, and then the darker green line is Derby. And because our numbers are smaller, we often look a bit more jagged, but you'll see that the trend over the 3 is very, very similar. We have a declining trend in the uptake, both locally, regionally, and nationally in these vaccines. There's a dotted line across there at 95%, which is the target level for the vaccination, that 95% of the population would receive it. And that's set there because that's felt to be a level at which vaccination of those individuals provides protection for the entire population. So when we reach that point, the chance of outbreaks is dramatically reduced. And you'll see that decline over time for those vaccinations. The bottom of that chart, it's at 92% on the left, so it's declining. It's still within the 90s, but you'll see that there's still a significant decline there. So the next slide, thanks, Linz. This one is for the MMR, which is given at just over a year old. This is the first dose, and this is measured when the children reach the age of 2. And you'll see similarly, the colours are all the same. We're the dark green line, but similarly, there's a decline nationally in the uptake of that vaccine. And the 95% line is particularly important here for measles, because there's really good evidence that if we fall below the 95% target for the MMR vaccination, that we are at risk of outbreaks of measles, as you'll be aware that we have been seeing more recently across the country. And the next slide, thanks, Vince. And then this one is the meningococcal ACWY, which is one of the school-aged vaccinations. So the 14 and 15-year-olds received this from the School-Aged Immunisation Service during the school day. And again, a really similar change. There were some good increases in improvement pre-pandemic. That's 1920, the point of the peak. And then since then, again, a decline in the uptake of those vaccinations. And locally, that's under the 75% uptake for those vaccines. So just wanted to show these just as an indication of this is a really, really challenging area to increase vaccination uptake. But it's not a local issue, it's a national and a regional issue as well that we're all working on. Thanks, Linz. So as far as what we've been doing, I think there's a really good opportunity as these programmes were being fully commissioned by NHS England on a regional basis, and that responsibility is in the process of transitioning towards ICBs, and we're now able to work really, really closely with ICB colleagues to look at really much more detail the commissioning of the local programmes. And that delegation, the full delegation, is expected in April of next year. We've also been working to reduce inequality and uptake. We did have a specific working group around inequality, and that work's now becoming embedded within the Vaccinum Delivery Board work. There was a national vaccination strategy which was published at the back end of last year, and there is some work locally to develop the response for Derby and Derbyshire to that. And then also to note, there's been significant work recently on increasing uptake in both measles and pertussis, the whooping cough vaccine. So you'll be aware that we did have outbreaks, particularly across the West Midlands, of measles over the recent months. And we've also now been seeing an increase in the levels of whooping cough. Whooping cough being very significant for small children, and unfortunately there have been some deaths nationally of babies from whooping cough. And that vaccination is particularly provided to pregnant women so that when babies are born, they're immediately protected from the antibodies that they get from their mother. And then it's given within that 8-week vaccination as well. Next slide, please. Oh, you've got it already. Thank you. So the next area was the specific consideration around vulnerable groups, and we have established a subgroup to the board looking particularly at vulnerable populations. And as we met together, there are a large number of vulnerable populations that we have identified, and so there was a need to start somewhere. So the belief of the group was that we should start with new arrivals to consider. So that could be international students coming to the university, it could be those seeking asylum, it could be new entrants into the UK for other reasons. And what we've done is undertaken some initial scoping of the priority issues and areas for those population groups, and we've used people who are linked into that to work with those groups in order to establish that understanding. So we've managed to develop some key areas that we need to progress the work on. And the other part that we've done is mapping the system, and only discovered in our conversations the complexity of the local and the regional and national meetings that take place regarding the new arrivals group. So we've been looking at mapping that and ensuring that we can find the areas where there's gaps in the work and not duplicate work that's happening elsewhere. And through that work, we're developing the work plan with the system colleagues who've joined us in that group to make sure that we're focusing on those key issues. And I'd be very happy to bring an update on that to the board as that develops further. Thanks, Linz. So the next area was the response to environmental hazards and emergency planning. And as mentioned, part of that has been strengthening our relationship with the Local Health Resilience Partnership, ensuring that reviews undertaken and work undertaken with the LHRP also comes to us for information, and we've been particularly looking at a system-wide health protection memorandum of understanding that's been developed. Also been looking at the outcomes of exercises, so ICB colleagues arranged an exercise to test the response for infectious disease, and we were involved in that, and we were able to look at the findings and the outcomes from that work. The Air Quality Working Group also reports to the Health and Protection Board annually. We're due to see the report from them in the autumn. And then we're also considering a question that was posed to us around our role in relation to climate change. And we're aware that there is significant work already being undertaken. So part of the action around that is to, again, a little bit like the vulnerable populations work, to look at what's happening elsewhere and to see if there's any gaps that the Health Protection Board should be covering. Thanks, Linz. So that's an update on where we are with the progress from the strategy. So very happy to have any questions.
Thanks, Robin. Would you mind turning the mic on? Thank you. Thanks for that. That was quite comprehensive. I did sort of wonder halfway through whether we should have taken questions as you went along, because it's quite a wide area to look at, isn't it? We've got a few people replacing others this afternoon. So if before you make a comment or question, if you could just say your name and who you're representing, that might be helpful. Thank you. And I would like to just admit right straight away at this point that we do actually have 3 councillors in the room. And I'd like to welcome Councillor Alison Holmes, who has joined the board this year. Thank you, Alison. Background in the NHS, so knows what she's talking about, I think. Thank you, Alison. So, Councillor Ashby, did you? Yeah.
Thank you very much, Robin. That's a great report, and great to hear about the improved input into care homes to improve their infection control. That's, I'm sure, vital and much appreciated, and good to see. I just wondered, thinking about vaccines and the level of vaccination achieved, particularly with flu vaccines, I'm wondering. I could ask questions about all of them, but I won't. I'll save you all the my personal interest. But since they're more dispersed across pharmacies now, as well as GP surgery, do we know whether the uptake has improved, stayed the same, deteriorated in the last couple of years?
So the latest data that I saw for last year was, I believe, for the older age groups, we remain relatively stable, but particularly for the working age adults who are at risk, that for that group, we have got a declining uptake. And I think it's, we were discussing this last week as to what that might be about, because there was exactly that question. Actually, there's been a lot of work to make flu vaccination much more available, and also with that pharmacy availability, much more sort of evening and weekend availability if it's difficult for working age adults to get there. So I think it is really challenging, because when you look at the direction of travel for all of those vaccinations, actually it looks fairly similar. And it's a much broader piece of work, I think, that we need to do around the importance of vaccination. Real challenge, yeah.
Thank you. First of all, Cathy.
Thank you. Thank you very much, Robin. It's Cathy McLean, Chair of the Integrated Care Board. So I had a few things. I mean, to be honest, I could ask 500 questions, but I'll confine it to a small number. But really helpful to hear where we are in this. I think your point about a complex system now is well made. And you also made a comment that some of the experience and knowledge may have got lost on the way. And I just wondered how you feel when you were able to mitigate that loss of knowledge. Are you comfortable with where we're up to? And kind of linked to that, it's great to see a strategy. It's got many elements to it. You've got a lot to do. But sometimes this is me now being very non-executive. What really worries you most? If we said to you from your position, of all that stuff, what would worry you most, I think? And then on that, how are we getting ourselves together? I just wonder if you have a sense of how we are compared with others. In other words, do you feel we're making as good progress as others? Could we go further? And very finally, we've got a COVID inquiry going on. We've seen the early reports from that, and I just wonder how you feel we're going to learn from that locally, as well as, so far it's been nationally focused, but other bits will come out. Thank you. Okay.
Thank you. I may need a reminder of the questions as we go through. I realised halfway through I should have been scribbling some notes. Just on the COVID inquiry, we do have a couple of slides on that towards the end, so perhaps we could pick that one up. What do I most worry about? So I think that must be the vaccinations, mustn't it? Because we know that is, as a healthcare intervention, that is the most effective thing that we can be doing. And it is clearly not a simple issue. all of the work, as mentioned, is done around improving availability, times, access. That's not the simple answer, is it, to this? There's far more that we need to address, and there will be a variety of different reasons for different people that they're not coming forward for that vaccination. That feels like the biggest mountain to climb. And literally, when you look at the charts, it's a long way back up that hill, isn't it, to where we were. So that's two of those questions. How are we doing compared to other areas was one.
Yeah, how have we mitigated the loss of experience and knowledge, and how are we getting on generally?
From a loss of experience, I think when I look just with a really narrow public health lens, I think before we entered the pandemic, we were in a really difficult position from a health protection perspective for any public health teams outside of Public Health England. So there was plenty of expertise there, but actually when you looked across the rest of the system, there wasn't necessarily a great deal because of that change in 2012 when people had been drawn in. I think actually the pandemic supported us as public health teams to develop expertise simply because everybody had to dive in and do the work. And we do have now, I mean, certainly within our team, we've got a number of members of the team who were involved in the response and who learned a great deal around health protection at that time. But that's a moment in time, isn't it? And that continuous development then doesn't necessarily happen. So that's why a part of the strategy for the Health Protection Board is to consider that approach to workforce, and that regional community of improvement. It's on their agenda to consider how we can share good practice and share development across the region, but that is very much focused on public health teams. And I think there's broader work beyond that, and I think infection prevention and control is a good example because. In reality, the specialist capacity of those nurses is small, isn't it? And I know when UHDB have been out to recruit for some of this pilot work, they've really struggled to find the expertise there. So there are definitely issues around that expertise within the system. And then how do we compare with other areas? So I think we have some areas that are much stronger, and I know that vaccination, although it doesn't look great on there, I know that generally speaking, Derby and Derbyshire perform well compared to other areas, particularly across the region when it comes to vaccination. And I think that the issue for me around infection control and care homes is the big one that stands out to me as being the one that feels as if we are dropping below where some other areas will be from that perspective. Have I answered? Brilliant, thank you.
Thank you, Kathy. Thanks, Robin. Councillor Kerr.
Yeah, thank you. It's there are two areas. Something's been picked up on already in terms of the vaccinations, and it's that earlier period. I think it was sort of 2013, 14, 15 when we were at an apparent peak. Have we been able to look back, and there's probably something that needs to be done nationally, as to why people were more receptive and prioritising vaccination at that time in a way they aren't now? Is there some learning from there that we are missing out on and we should be picking up on? Obviously, there were lots of other things you're planning to do, but I don't know if looking back would help. And my second point is the work with the care homes, which I think it sounds really positive to have people going in and doing that work. My father's recently gone into a care home, and two of the things that we as a family were keen that he continued to do, first was exercises to help prevent falls, which he had done on a weekly basis, was something to be originally set up and supported by the council, and now then run independently. And secondly, to continue to take vitamin D. We have achieved both of those, but the care homes said they could not give anything that they considered to be medication without the GP prescribing it. So as the vitamin D had just been bought in a bottle from the pharmacy, they couldn't give it to him. And something as simple as that, which obviously NICE recommends people to be taking, particularly if you're not getting out and about in the summer even, if that is common to most care homes, then is that something that could be approached with them or managed in some way just to help doing the protections. And the support that we've had in terms of the falls and getting some exercise going with falls has been very positive. I don't know whether that would have happened without us initiating it, because it's quite a small home. But that would also be something that prevention is better than cure.
Just on the first question, no, we don't know why. I have an observation which may not be any form of evidence. There may just be, as I look at it, in my view, but there were some really significant changes from an NHS perspective in 2012-2013, and the responsibility for the commissioning of immunisation services moved to a regional level. So previously, we had a member of the team in the city and one in the county whose job was around vaccination immunisation. I don't know if you remember, working directly with practices, doing all of that work to encourage uptake. And at that point, those members of staff moved to the regional teams, and the type of work was very different because it was done at a regional level and not at a local level. I don't know whether, I couldn't say whether that's why this has changed. It just happens to be at that time, doesn't it? But I think that's the really positive opportunity around the change that we've got coming, because the responsibility is coming back to the ICB. I mean, the team is already there doing this, but the full delegation will be next April. I think it just gives us that real opportunity to have a local approach to it that we lost when things moved regionally. Above and beyond that, there's also everything else that's happened around vaccination over this time, isn't there, which I think is another hill to climb. But I do feel that was a big loss, and we will regain that ability to work much more closely locally. On the care homes, I don't know, I can see Pervez over there, so I don't know whether Pervez has any thought about care homes giving over-the-counter preparations. I mean, vitamins, it should... I don't know.
It sounds like a bit of a storm in a teacup, doesn't it, really? I think we do have a DCC sort of medication policy, but I wouldn't have thought vitamin D would be categorised as a medication. I wouldn't naturally think of it as a medication, and therefore I think it's probably just a confined issue to that particular care home and being particularly risk averse, and whether we can have a dialogue with that. But if you can tell me the name of the home, we can go back to them through the commissioning route and speak to them about that particular practice.
And perhaps we'll not share that here, obviously.
No.
Councillor Kerr, I know you probably wouldn't.
My point is that if you're in a care home, you're not getting outside, even in, you might have a brief period outside occasionally in the summer.
Understand that.
But everybody should automatically be having vitamin D, and if it's not being prescribed, it's probably not happening.
Thank you, Councillor Kerr. I mean, just before I bring in, is this specifically on a vitamin D point? And before you speak, Chris, yes or no? Is it vitamin D or is it? Oh, goodness. Honestly, how? Isn't that CEO yes and no? Go on then. I had a point, but I'm going to defer to you, Chris.
Well, I think on the vitamin D question, we've had a bit of a conversation at Health and Wellbeing Board before about the evidence base. So I'm not sure we go back into that. There is a national view around vitamin D, and we follow it from an NHS perspective. So the point I want to make is a broader point, not in relation to this care home and vitamin D. It is around the balance between health and care services, and what we've been trying to do over years about creating a different workforce that takes on more broader roles, particularly around care, and this boundary that's existed between typical NHS roles, care roles, and it's an ongoing piece of work that we're all involved in around extending the scope of all colleagues that attend So that's something that we probably bring back to a different form, probably not this one, but a different one, about how we're developing health and care. But thank you. Yes and no.
Thank you, Chris. Yeah, absolutely. And I suppose before I bring Councillor Ashby back in, I did want to kind of put the colleagues over here on the spot, because but you have already been referred to. I suppose in relation to Robin, I mean, I imagine everyone's working together anyway, but in relation to Robin's concerns around infection control and care homes, and what Chris has just said in terms of sort of blurring those boundaries. I mean, I know this isn't a magic bullet, Gamal, but we do have the new commissioning strategy coming in, don't we, where you are going to set a framework for providers, and obviously you're very familiar with all the current practices that happen, Pervez. So is there more that could be done collectively in terms of working the care homes, with the care homes, from an oversight or a commissioning perspective, or indeed an improvement perspective? Is there more that we could be doing from within the council's ASC and public health team? Thank you.
Yeah, thank you, Alison. Happy to have a conversation with Robin and Pervez, and we'll take it offline to sort of see if there's further that we can do and incorporate into any commissioning contracts or engage with the market. So happy to consider that.
But certainly, you know, it is fair to say that prior to COVID, infection control measures within the care home environment were very, very weak. And that period did shine a light on that, and that deficit in particular. I think we've moved a long way since then. However, there's always sort of room for improvement, and I think care home management have become much more familiar with the issues around infection prevention and control, and it's kind of ebbed its way into sort of normal practice. But then, you know, that gives rise to cost, that gives rise to additional responsibility, and that then is reflected in fees, etc., etc. So I think we've got to have a dialogue about what is acceptable, because if we're expecting hospital standard infection control environments in care homes, then that's a different ask to saying something of a lesser order. So we just have to be clear what it is that we want and what provides us with sufficient reassurance to give us a sound basis for protecting people in those situations.
Did you want to come back on?
No, I'm just going to thank Gamal particularly. Yeah, we can have a chat, Gamal, can't we? And there is some ongoing work to look at how this can be resolved. Yeah.
Okay, thanks. So I think, as Chris suggested, maybe this is something we should return to as a board, take stock of where different partners are up to with this important issue. I realise there has been progress. Sometimes, you know, when there's progress, it reveals not only how much wasn't being done, but how much there still ought to be done. Thank you. So Amjad.
Thank you, Robin, for the report. Amjad Ashraf, Derby Health and Equalities Partnership. Robin, my question is more around the ethnicity data, so uptake within our ethnic minority communities in the city. What does that look like? Because through the pandemic, again, you know, COVID infected and spread within our communities at a disproportionate level. Is that reflected within this strategy, and if so, how?
So I think the data is a challenge, I would say. I think during COVID we had some really good mechanisms for making sure that was really accurate, and it is not as robust now, I would say. But what we are doing through the vaccine delivery group, as I mentioned, there's a building in and embedding of that health inequalities work that was done previously to make sure that it's not seen as a separate part of the work. I think that's part of the idea of bringing it into the board, was not to be something at the side where people are doing health inequalities, but actually bringing it and embedding it into the work and the strategy development that they're doing. So it's something that the team are looking really closely at, but we can definitely do more.
Yeah, because on that, from the insight we have, one of the major contributing factors to low uptake within our ethnic minority communities within the city, especially in our deprived wards, is that trust. And again, it comes back. And I think it's important we can put out as much initiatives and interventions as we want until we don't work collectively as a system to build trust within our communities. We probably won't see the desired support that we want.
Yeah, thank you. I absolutely agree. And that was one of the key findings, wasn't it, from the consultation that we did as well around vaccine uptake. Yeah, it's absolutely about trust. Yeah.
So thank you. So I did slightly, you had already spoken, Councillor Ashby, before I bring Councillor Ashby in and then Kim. So just on that point then, Robin, I mean, I know, and I know there's lots of work ongoing through the Derby Health Inequalities Partnership and elsewhere, and there's a sense that there needs to be a building up of trust. Is this something, clearly, we are within time on this item, but there are further questions. But this is a really important point, and I'm just wondering if this is something we want to dwell on a little longer now, in terms of whether you want to share some thoughts, Amjad, about what just say we need to build trust, but what would that mean? What does that take? What could happen? Or whether that's something we might specifically bring back as an item to another meeting, because I know there is some work ongoing. Well, I hope there is work. I trust that, I believe there is work ongoing in this area. Thanks.
If we start on this, we'll probably take up most of the meeting. So I would say we'll probably come back. There is work happening, and probably come back and present to the board some of our further findings and stuff. But as a system, I think it's something that unfortunately we're not seeing enough of reflected within strategies and policies, this trust element and building trust. And that was one of the main learnings coming out of the COVID and that disparities report Public Health England produced. So yeah, we'll bring it back.
Okay, thanks, Amjad. Well, as you'd raised it here, I think, thank you for that. I think we won't focusing on it today, as you suggest, because but what we do want to do is recognise and acknowledge that it is a very significant issue, and we have added it to the work programme, and we will bring it back, and we can have a proper focus on that and see how everyone can engage with that issue. Thank you. Councillor Ashby.
Just a couple of quick points, and one of them borders a little bit on Amjad's point as well. In terms of the vaccine uptake, I agree completely with you, what you said earlier, Robin, about the change that happened in 2012, 2013. What I would be inclined to say from my experience was certainly back then and ongoing since then, you've got a lot of practice nurses who are really passionate about vaccination and uptake. But I believe there certainly was quoted research pre-2011, 12, that, if GPs gave brief interventions in all sorts of things, the original work I think was done with smoking and weight loss, and simply said to the patients, you need to lose weight or you need to think about stopping smoking, up to 10% of patients will do it because the GP says it. And I just wonder whether there's a piece of work that could be done with GPs with regards to encouraging people to build that trust and encourage vaccine uptake, because very much in general practice now, that's the nurses' area. But maybe in GP training and other courses, just encouraging the GPs to engage may help to just turn that curve a bit. If I can comment on the vitamin D, I would doubt, again, from my personal experience, both working in nursing homes and in general practice, I would be very surprised if the care home that Lucy's dad is in is the only one that won't give anything unless it's written on the mark sheet. So I would have thought if you could give some sort of blanket advice that actually, which I do completely agree with you, all of us, let alone the elderly, frail people in care homes, should be taking vitamin D. Just to tell, give care homes advice that they can give it over the counter, 10 milligrams or 25 milligrams, you can call it on that. But, blanket advice across the city and the county would actually perhaps help all sorts of aspects of life for those elderly frail people.
Thank you, Carmel. So I think that was more a comment, wasn't it, than there was a GP issue, wasn't there? Do you want to come back on the... I suggest that we have spoken about the vitamin D before, and there's a very good point, and I know that members of the board are going to take this away and look at the ongoing issue of infection control anyway, but thank you for that point. So if you just respond on the GP, Robin, thanks.
Thank you. Yeah, we know the power, don't we, of a trusted GP's voice. It's very powerful. And I'm just thinking, but I've just added to my mental list, I have an opportunity to speak to the GP registrars at their Child Health Conference every autumn. So perhaps I'll definitely add that to my... I do usually have a conversation about vaccination, but perhaps that importance of them promoting vaccination, definitely add that to my list.
Thank you. Everything always seems to go back to the GPs, doesn't it? The great, the centre of the system that everyone believes in, I think. Thank you. Kim.
Thank you. Kim Harper, Community Action Derby. It was really to build on what Amjad had said, and also I think a practical offer. You're probably aware, Robin, that we're working with the New Arrivals Alliance in the city. So from my perspective, a new starting point around vulnerable people, an offer to engage with that, because we're looking at a strategy for how new arrivals is integrated in the system and how we can best support them. So, yeah, practical offer really to have a chat to us.
Yeah, thank you. And Rich has joined us.
Amazing.
Yeah, Rich has joined us in our group. I think we let him be in his job about a day, I think, before we had him in. But
it's really nice to know the system is working, isn't it? Okay, thank you.
Thank you, Kim. Thank you for that. Thanks, Chris. Thank you for that offer of support. Would you mind turning your mic off, please? Thank you. Yes, because the purpose of this report is to both note the progress in implementing the health protection strategy and also see in ways that members might support the delivery of the actions. So I'm going to bring in Councillor Alison Holmes now, and then I'm going to draw the general discussion to a close on this item. But if people have any further comments they would want to make about how to support the delivery of the strategy, I think we will still take those and then we'll move on. Alison, thank you.
Thank you, Chair. Sorry, I'll be brief. I appreciate that vaccines are personal choice, but do we actually have any data on why people are not, particularly children, vaccinating children against anything? Are we able to ask, do we have any data on that? I've been made aware of several bloggers, TikTokers now, anti-vaccine messages, and more kids watching that, and I think it's a terrible influence, and I wondered if you were aware of that and if anything would be done with it.
Thank you. So I think I would say that we don't have the data, but there is plenty of research that's been looking at this area, and fair to say that there'll be lots and lots of different reasons, some of them really practical as to why vaccination uptake isn't better. Some will be about simply understanding the need for the vaccine or the communication about the appointment. Some will be about practical access issues. Some will be around concerns around vaccination, as you said, the influence of social media and the work that's being undertaken to try and ensure that people can access the right information in order to make that decision. I think it's really important that our aim should really be that 100% of people have the right information that they need in order to make the choice about vaccination. And I certainly believe that if people have the right information to make the choice, then the majority of people will choose to be vaccinated. But it is really challenging to counteract that narrative, particularly when we're not necessarily of the age of some of the young people, don't necessarily have access to those social media posts or know that they're happening, but it's certainly part of the work that we're doing to understand.
Thank you, Robin. Thank you very much, everyone. We have certainly noted the progress in this area. Did anybody else have any further comments around supporting the delivery of some of these of the actions and some of the issues that Robin's outlined today? Ian?
Yes, thank you. Ian Fulliger, Head of Strategic Housing at the Council. Robin, it's really just a question. Do you think colleagues in housing and possibly social care could be doing more to promote the message? Obviously, we got 12,000 council houses, a further 8,000 housing association houses in the city. Anecdotally, those residents might be some of those who aren't getting vaccinated. Could we help? We obviously have communication channels with those tenants. Could we help get messages out there, or is it more complex than just getting messages out there? I appreciate it is a very complex area in terms of why people don't take up the vaccine.
Thank you. And in a simple way, yes, I'm sure that there is more. It is more complex. Most of the individuals that are called for vaccination will have received an invitation. So most of the families will have received a direct invitation from their GP practice to go. But there must be more that we can do to support people to access that. So be very happy. I know there's been some other work that members of the team have been doing around housing, so perhaps there's something we can link together. Be really interested. Thank you.
Thanks, Ian. I think that's a really generous and good offer, actually. I mean, as Robin said, if you get an invitation from your GP, I said they seem to go on phones and things now, don't they? Not, I mean, everybody's glued to their phones, but I don't know, something from your housing provider might be quite an interesting angle. So I think that's really possibly a very fruitful suggestion. Thank you. Lee.
Thank you, Lee Sharrod, Head of Integration at UHCB. Robin, I was speaking to a colleague up at Nottingham University Hospitals recently who was describing how they supported in the delivery of flu vaccination, specifically on behalf of other partners in the system, and had seen an increase in vaccine uptake, partly as a result of that. It's just an offer to say that we'd be really happy to have a conversation to look at how we might be able to support differently to how we might now, to see if we can help to drive up that uptake in the community.
Fantastic, thank you. Thank you.
Thank you very much. Any other concrete offers there? Any more coming in? Any more from Paul over there? You've got enough on your plate? Yeah, okay. Right, well, thank you very much for all that input. Thank you to Robin for a really comprehensive report, and thank you for the offers of support. And I look forward to receiving a few updates on and reports on areas we discussed as part of that. Thank you. Unfortunately, the Health Watch... Pardon? I thought you were going to roll those both into one, Robin. I thought we'd finished there. You're not finished?
Apologies. I put the questions in the middle because I thought it was quite a long...
Oh, right. Well, apologies to the room. So the 2 points. Apologies to the room because I thought Robin had finished, and that's why I allowed the questioning to go on for so long. The other side to that is that the Health Watch report, we don't, unfortunately, both possible presenters are ill, so we don't have a Health Watch report this afternoon. So it does mean we can spend a little bit longer on this report. So, Robin, thank you. I thought you'd finished.
Apologies, but this is a very quick second part to it, because we do always bring an update from the Health Protection Board, and all I've done today is just put some heading down for myself because I thought we may have covered most of these areas in the conversation already. If you just go back, that's it, lovely, thank you. So I think just to note, so these are the areas that the Health Protection Board discussed, which relates directly to the strategy, and there are some other areas within there. just to note, I don't think we've talked about tuberculosis. So there is a particular piece of work drawing together the work of both the Chesterfield and Derby TB services, and to look at their work and to see what additional support they need. The world of TB has changed significantly since their specifications were written. So we are looking to support them to see what might need to be proposed as a change for their services. We've also developing a risk register, and part of that is to support our communication across the system, and particularly developing our route into the system quality group within the ICB and reporting of any risks we identify. So they were the only two areas really I needed to update on from the last meeting. So there were just two other things to mention. One was the National Screening Programme. So they do sit within the health protection remit. They are currently commissioned by NHS England through various local providers, as you'll see. So the GPs provide the cervical screening. There's a specialist service for aortic aneurysm screening, and you'll see there's programmes there around pregnancy and newborn that are delivered through maternity services. So there's a variety of different mechanisms for their delivery. And the screening programmes are currently under consideration as to whether the responsibility for the commissioning of them will be transferred over to ICBs, whether that be next April or whether that be later on. So we're still waiting to hear. We understand that that's probably a new government review and consideration as to whether that's going to happen. What I would say is, similar to the vaccination and immunisation services, I think it would be incredibly positive if that did come back to us locally, because it does give us that opportunity to work to help the services to really fit our population and to have that local view of them. So it was just to let you know the breadth of the programmes that there are, and that potential is that it may be coming locally. And then next slide. So, and I just really wanted to use this as a way to mention the COVID inquiry. So the Module 1 report has been produced, and some really significant learning from that. And I think that first bullet point is really, really clear. We prepared for the wrong pandemic, and I think we all knew that once we'd started, that we were prepared for flu, and responding to flu was not what we needed to do when responding to COVID. So there's some detail in the report that's come around the findings and around what needs to change, and that's partly around the structures for emergency planning, partly, as I said, around the single focus on flu, partly around the ownership and oversight nationally around these issues and the civil contingency structures. And then also consideration about the advice and how advice is shared and how we avoid groupthink, which I think is a really, really key part to this, how different voices and different specialists can be heard within this area. But if we just move on to the next slide, Linz. Thank you. So these were some of the key recommendations that were coming out from the first module. And the key areas for us really is that recommendation to change in the civil contingency structures. So we're anticipating there will be some changes around emergency planning, that there will be a national strategy with a regular review, that there'll be a requirement for us to exercise locally a response to the pandemic, and it's in the recommendations it's every 3 years, with some clear reporting around the findings and the actions from that. And there's also, I think, a really positive note at the end there, which is around the benefit of working with people who have something to contribute and who have knowledge. And particularly there it notes engagement with the voluntary community sector, social enterprises, and I would also note Directors of Public Health as well, that they've managed to squeeze in there as well in those recommendations. But I think it's just a really positive recognition that actually there was local knowledge and expertise that could have been used much better and wasn't, and a need to make the most of that. So thanks, Linz. That was just a quick run through. That's the end of my presentation.
Thanks, Robin. Obviously, I mean, I didn't get that in advance I didn't get those detailed things. There was no appendix, was there? I didn't receive it. So, I mean, it would have been interesting to see that in advance, but not to worry. I mean, I think on the COVID inquiry, it's something we do need to come back to as quite a long, specific item, perhaps when the Commission has reported more on it.
Yes.
I think I would say, as a small plug for us locally, is that we did do a topic review on our scrutiny board here, and some of our conclusions, they've concurred with some of our conclusions, notably that, you know, I mean, it was widely felt then they were preparing for the wrong problem, and secondly, the kind of top-down model and with the lack of fluidity and sharing information both ways, and not really listening to people on the ground who actually could see that things were going wrong. And also, you know, bizarrely for systems like this, but not alien to people like me with a background in philosophy, is actually preparing for the unknown. So, because if you're always, you know, that concept of actually, you know, because you're always looking in preparations, but you may always be faced with the unknown. So always having that space to actually think, well, if this is new, then how can you prepare for that? Because to some extent you can't. But anyway, they were some of our local recommendations. I'm pleased to see that they found some of them. No, but it's a very serious issue, and we must discuss that in greater length. I think given the time we've spent on this today, I'd probably prefer if we don't particularly, unless anybody's got any burning questions on that particular report. I mean, it's such a big issue. I think we should come back to it in more detail. But I don't know if anybody wants to respond to the commissioning of screening services from the ICB, or do you want to make any comments in response to that? Sorry?
Right, well, thank you. Only that we support what Robin shared, hoping that we will get those back into the ICB and work very closely, more locally on that. And we are expecting them to come back, if not next year, the year after.
Thank you, thank you.
Just a very quick comment, that last recommendation in terms of the worth of the voluntary sector, I suppose that cuts across all of system activities wherever we're seeing a major inequality. So a wider conversation at some point once that report's done will be welcomed.
Robin?
Thank you. And yeah, just apologies for the late entry of that. It was only published last Thursday. So if it'd be really good to have a full consideration. I think the modules are still ongoing, but perhaps as each module is published, we can have some consideration of the local impact of that.
No, absolutely. I mean, it's a vast area, but definitely we should look at it in more depth at an appropriate time. Thank you, Robin. Any more comment, Cathy?
Just a quick one. So I would agree with that. I think it's something to come back to. But I suppose given that everybody talks about it, it's about when, not if, we have a further pandemic. And this inquiry is going to take some time to roll out all its modules. It's done one in quite a long period of time. I suppose the question I would hope we might address when we come back to it is, do we feel we are genuinely better prepared now? And what as a system are we doing to help ourselves on that, which links back to the health protection bit as well. But, so not for debate, but I do think it's an important question, because we might be waiting some time for it all to come out, but it could happen.
Okay, thank you. That's a really fair point. I guess, would it make sense, Robin, because I haven't really spoken to you about this, in the light of, I think Cathy makes a really good point. And I feel that, well, we're not running out of time for this meeting, but I feel we have covered, it's quite a lot for people to absorb, I think, the information you've given out. So I'm just wondering whether this is something we could perhaps bring back to the next meeting. Is that too soon, where we could actually, and partners could prepare some reflection themselves, perhaps in response to a report that you lead on about the question that Cathy has quite rightly raised?
Very, very happy to do that,
Okay, thank you. Because although, you know, obviously we must respect the work that's being done in the COVID inquiry, as Cathy said, it's with some. Well, we're not out of COVID as such, but we're out of a designated pandemic, haven't we? And have been for some time, and time's moving on. And you know, before we know it, we could be preparing for the next pandemic on what we've already learned from COVID, and it isn't a COVID pandemic. So, you know, brilliant. So next time then, thank you. So as I said just a moment ago, thank you very much, Robin. We don't have this Health Watch report this afternoon because unfortunately both presenters are, potential presenters are unwell or unable to attend. So we look forward to perhaps receiving that next time or another time, because it is an important piece of research. I'd rather not discuss that without someone from Health Watch here, if that's okay with everybody. So we'll move very quickly on then to the Better Care Fund submission, which is being presented by Gamal Nizar. Thank you.
Thank you, Alison. I'll talk through the report if that's okay, drawing out key points, then happy to take any questions if that's okay. So, Chair, this is an update on the revised Better Care Fund. Just a little bit of background context as the report sets out. Of course, Health and Wellbeing Board approved back in 2023 the Derby BCF plan for 2 years, the 2023-25 period. Since then, the Department for Health and Social Care has announced increases to the discharge fund monies available to the local area, and 4.1 outlines that for Derby, the discharge fund allocation for 23-24 was 1.6 million, and good news in the sense of in 24-25 that increased to 2.1 million, and that's what this report focuses on. 4.2 outlines the areas of spend for the Better Care Fund, which I won't run through in detail. And then a little bit more context, kind of final paragraph of 4.2. 2.8 million is what Derby City Council received for discharge fund, and 2.1 million is what came through to Derby and Derbyshire ICB as additional funding, which was really, really welcome and good news. 4.3, middle of 4.3 outlines what are the conditions of the BCF fund in terms of national conditions and the areas of spend in relation to BCF. Appendix 2 is what was submitted to Department for Health and Social Care for the deadline of 10th of June, and that, of course, we discussed with the Chair of the Health and Wellbeing Board, and these were NHSE deadlines that we were required to submit by in terms of use of the discharge fund. And Appendix 2, or 1, I think it is actually, outlines the areas and a breakdown of what that funding is being used for. And then also, Chair, just to update in terms of 4.5 outlines the really effective integration that the Council has with Derbyshire Community Health Services and the changes made from March 24, where the Derby Community First Service team combining council aspects of teams that were underway, linking them with DCHS and that Section 75 agreement, and that area of work is progressing, which is good news. And Chair, finally, recommendation 2.1 outlines in terms of approval for that discharge fund in the BCF, but noting that, of course, we had to make that submission by 10th of June as required by NHSE. Happy to take any questions.
Thank you, Gamal. Just so I have a printed copy of the. I only have printed copies. I reassure everybody when I'm actually chairing a meeting. Otherwise, I use online like everybody else and don't use paper. But I don't know if it's just an accident of the printing. But I don't. I have gone through the detail of this with you separately some weeks ago prior to this meeting. So I've seen Appendix 2, but I don't have Appendix 2 as part of my documents pack here. Was Appendix 2 not shared?
Thank you, Chair. I think there's been an issue because I think once you convert them to PDF, there's an embedded Excel document, which I'm more referring to Appendix 2, I think, which is, I'm happy to send that, circulate that separately.
I mean, I suppose the point of my question is, sorry, is that because I haven't sort of sought this because I've already gone through it in some detail with yourself. So has everybody satisfied that they've seen the information they need on this? Or, sorry, Councillor Ashby? Use the mic.
Beg your pardon. The link to Excel, Appendix 2, the Excel chart would not open. So we've not seen that. We've seen Appendix 1, but not 2.
Mail.
Yeah, thank you. We'll arrange to circulate. That's a fairly detailed spreadsheet for the full breakdown, but very happy. I think it's with the embedding, it's kind of got lost in there, but happy to circulate that separate from the meeting. But Chair, just to clarify, the important bit is really around the additional components around Appendix 1, but very happy and one for us to look out for when we convert reports to PDF.
Thank you. I have seen it myself, and I would say it's incredibly detailed. It's micro detail upon micro detail. But I think just for future reference, before I bring Kim and Cathy in, if anybody doesn't have any information is concerned, then please get in touch. And Lindsay can follow that through, can't you, Lindsay? Or I will follow it through with Lindsay. So Kim first.
Thank you, Chair. I think it's a really good report, and obviously quite detailed from that perspective. I think I did at the Integrated Care Partnership Board ask about the fund, because it seems as voluntary and community sector are very much part of delivery across an integrated system. It isn't really integrated into this particular programme. So I think we've almost missed an opportunity if we've looked at the detail without the voluntary and community sector and the enterprise sector being part of it. Are we looking for that to happen moving forward? Or do we have something that's already delivered within that final appendix, I guess? I think it's important that the voluntary and community sector are reflected in part of that as delivery agents as well, I guess. And I did raise it previously, but not within the Health and Wellbeing Board, so.
Okay, thanks, Kim. Would you mind turning your mic? Thanks. Gamal, do you want to respond to that?
Yeah, I believe so. I guess the reason I'm slightly hesitant is around to actually know, well, what sits behind these complex lines and who's going to be delivering what. But certainly, you know, happy to take back into the system around which are the providers that are providing some of the components that sit behind this, and there isn't a closed door. It's more around, I guess, around providers that can suitably deliver some of that, those sort of services and areas of expenditure outlined.
Thank you, Gamal. I mean, we did say we'd meet Kim, didn't we, anyway, and we haven't. I think we have got a meeting in the diary now just to talk. Obviously, if you want any detail around this, I'm not offering that, but we talked about the strategic involvement of the voluntary sector more within the ICP and the health framework, so we need to meet and talk about that, don't we?
Agree. Thank you, Chair. And I think it is, for me, it's from the start. It is the collaboration piece that I think sometimes in the charge to get things done, because I recognise that we do have to meet deadlines, that as a sector we're not part of those discussions. So I think it's just about noting that, really, from my perspective. Thank you.
Okay, thank you for that, and I'll look forward to when we can talk in more detail. Cathy.
Thank you, and thank you for the paper. It's really helpful. I mean, I think I note that obviously it has been submitted now, which is fine, and I think we're fortunate that there has been quite an increase in it. And although we always want more, in that, you know, even more would be better, but it's a really important fund, isn't it, in terms of the jointness of it. It's really truly a joint. You know, it's called the Better Care Fund. It is genuinely joint. The bit that's going forward, I think, would be, I'm sure, is in place, but I would just like to emphasise the importance of being clear between us all the benefit of it, because that has again increased. How are we going to know at the end of the year how we've used this in a helpful way and that it's actually facilitated the aims of the overall system? So it's really just a question about how will we know we've used it well.
And now, a familiar question from you, Cathy, and a good one, thank you. Is that before I bring in Councillor Ashby, I think I'm not sure Kathy's seeking a direct, a detailed answer to that, but as a point of reflection, Pervez or Gamal or Andy even, do you want to come in on any of that?
Yeah, I'm happy to have a stab at that for Kathy. I think, you know, this fund, in the strategic context, this is our opportunity for that left shift. Absolutely, in terms of stop investing in more preventative services. And if you look down the list, you will see a lot of what is being invested in are more upstream services. And quite rightly, Kathy, all of those we need to evaluate individually to make sure they are providing us with the right outcomes and value for money. However, as a direction of travel, this is really, really important to signal because we know there is an underinvestment in prevention locally, and that's why we have got the hospital that's packed to the gunnels. We've got a health profile in the city that's not where we want it. It's to the left of the national profile. We've got obesity, we've got smoking prevalence, all above where we should be. So strategically, it's really important, but also the fact that we do get value for money out of it. And just to answer Kim's question, there are some schemes in there that are where the voluntary sector are funded, like dementia support, carers, hospital to home schemes, which are provided by voluntary sector providers. So there is no exclusivity in terms of who gets what's on offer from the fund. I guess the most important thing is, are we actually seeing a change in the health profile of the population, and is this actually absolutely promoting population health and supporting us with improving that population health? But yeah, Kathy's point is absolutely valid, and there will be some metrics around the schemes themselves, but also overall that are monitored to understand the effectiveness of the BCF.
Thank you, Pervez. Well, maybe at some point then we could have some sort of reflection on that, just into on the points you made and in response to what Kathy said. I'm with Kathy, but I'm also really aware that if you set yourself too high, a stringent a task in sort of measuring things, you're trying to measure things that can't be measured, or sometimes where they can be measured. If you haven't got a mechanism in place, it's difficult. It might be difficult to do that because we don't have the funding. But where we have the evidence, where we have the funding, or where we have the knowledge, then perhaps we could have some feedback on that to show just how beneficial, the fund is and some of the outcomes at some point. Thank you. Is that okay, Kathy?
Yes, thanks. That's absolutely fine. I suppose behind my question is really the points you're making about that shift to the left. So, in other words, over time, as we do this each year, how do we not just end up with a sump that actually wants more and more money, but actually we make a difference so that it doesn't? I don't know if I've explained myself, but so that actually we start to stop some of the things that are in there, having to have all the people in hospital and so on. So I think it's that wider, how do we add this to the overall aims that we're trying to do? So that's all really. So thank you.
It's a fair point, and I think they are fairly wide. It's good to ask the big questions, and I suppose that's a broad strategy, isn't it, of both the Health and Wellbeing Board and the ICP, and all the work that's happening in our neighbourhoods, some of our neighbourhood teams, and so it's a massive ask, public health, and but yeah, some more reflection on all those points at some times and how they all add up would be a useful thing to bring back. Thank you. Yeah. Have I missed you again, Councillor Ashby? Did you want to come in? I know that others do.
I just have one very quick point. It would be really useful if we could have a key to abbreviations. Appendix 1 is full of abbreviations. I'm not asking for explanations of them now, but for those who are in the know, you probably know exactly what everything means, but the rest of us don't necessarily, so a lot of it goes on trust because we don't actually know. So next time, when we have this sort of report, if we could have a key to abbreviations, please.
Thank you. So we need a passage on a reflective passion on outcomes and a glossary. Thank you. But it's a fair point. It's a fair point. It's impossible to know all these initialisms. Councillor Kerr.
Yeah, thank you. This is really helpful extra money, and it's obviously it's good to have it coming, but I think it's also we've had not very long to sort out what we want to do with it. I'm really hopeful that this will give us extra capacity and the potential for people to have opportunity conversations, so that some of the comments that we've had about the working we've been doing with care homes, for example, to be able to spend an extra 5 minutes and go through how they're behaving, so that we can do some of the wider messaging, like in the GP surgery, saying, oh, your son's going to need to have a jab in the next couple of weeks, don't miss it, will you? You know, those sorts of little messages that can reinforce the other messaging. And if we can think about what those key messages are and brief the people who are going in to make sure they're having those conversations with this little bit of extra capacity, that might be one way that we can multiply up the benefits.
Thank you, Lucy. Thank you. Margaret.
Yeah, building on Cathy's point and the measures, I think anyone affected by this fund knows at an individual level it makes all the difference not to go to hospital, not to decompensate, not to clog up A&E, but to be cared for in the safety of their own home. I think at a general level it's much harder to measure, isn't it? Because how much time is saved by A&E? You don't know what would have happened if all those people would have gone. You know, it's really quite hard. And I wonder if there's scope for thinking about what can be measured as we make this left shift, what can't be measured but we know matters, and therefore you can still use anecdote and not necessarily very scientific, but absolutely know it's working, and then look at where any money might be wasted, because there probably are some things that we do and they don't work. So I think, I said, building on everything that's been said, it really is worth having a good look at this, because this sort of money and this sort of direction is the way we're all trying to head, isn't it? And therefore anything that heads us in that direction is really useful to understand fully how it works, whether it works, what could work even better. Thank you.
Thank you. I think that's a really excellent point. I think there is a review happening or ongoing, isn't there, about the Better Care Fund already, isn't there, Gunnar?
Yeah, thank you, Chair. Certainly a lot of discussion on the Better Care Fund as a whole, and certainly a lot of monitoring at NHSE level for all the various lines, including discharge. But I think the comments and observations make perfect sense for us to look at a lens through the system to sort of say, if you just put a ring around discharge fund, impact outcome, and how would we demonstrate that with some sensible indicators rather than hard and fast as colleagues have outlined. So happy to consider that and work with colleagues across the system in terms of reflection.
Yeah, and just to reassure you, I don't think, as the chair here, I'm going to just stipulate this. There's no way that we want anything that looks like one NHS England. I mean, a reflective thinking through of what some of the outcomes are, and some facts, and some pointed as to where we cannot ascertain facts. This is all good, but this is quite high-level stuff. We're not going to engage in a line-by-line analysis of the spend of the Better Care Fund in this committee, which would be pointless and a waste of time and not get us anywhere anyway.
Thank you, Chair. I'm delighted with that, because the Excel spreadsheet has got more tabs on it than anybody who likes Excel, so appreciate that.
Too many people in the civil service trained in a tradition of empiricism rather than speculative thought, as you get more on the European side. Okay, I just had to get that one in as we progress. Thank you very much for that. So we need to agree this, don't we, as a Health and Wellbeing Board, and accept the report and agree the recommendations. Do we, as a Health and Wellbeing Board, agree and accept these recommendations and the submission? Right, thank you very much. Right, so quickly moving on then to Gamal again about a board which is going to be integrated into our own, this particular board. That's the proposal, isn't it, Gamal? Thank you.
Thank you, Alison. I'll be brief on this one. So the report sets out the details. Brief context is that we have had a Children and Families Learners Board running for a number of years. And over that time, at one point it was a statutory board, and then it moved into a non-statutory board, but we kept that running in the context of the Children and Young People's Plan. Following reflections and streamlining of processes, we've had sort of discussions internally, and of course I know as Chair, yourself and the Cabinet Member for Children's Services, around there are some synergies with Health and Wellbeing Board, and the proposal this report sets out is to dissolve the Children and Families Learners Board and incorporate some of those priority areas outlined in the plan to be part of the remit of Health and Wellbeing Board, because children's is also discussed within this space, and there's certainly some benefits within that. The report sets out the 3 areas that are within the plan itself, which I won't go through in detail. But certainly we feel there are synergies within that, and generally there is support in order to move away from double running, in effect, of having a Children and Families Learners Board and also a Health and Wellbeing Board, and trying to incorporate into this space certainly the aspects of the priorities outlined in the plan. So happy to take any questions, Chair.
Thank you, Gamal. I have been briefed on this. It seems a good idea to me. I can report as well that Councillor Paul Heselgrave, who is the new Cabinet Member for Children and Young People, replacing Councillor Whitby, told me yesterday he's fully in support of this initiative. I think it's in the spirit of not suppressing analysis or discussion, but suppressing the number of meetings set up where you often have the same people attending, so it's a kind of bureaucratic efficiency rather than suppressing debate or sharing of knowledge. So do we have any comments on this proposal? No? We have 2 recommendations to obviously reposition this board, the Children Families Learner Board within this board. Do the Health and Wellbeing Board accept that? Getting nods around the room, thank you. And then the other 2.2 I see is to review the Health and Wellbeing Board's membership to incorporate the relevant representation from CFLB who are not already members. What about that? I mean, I have a suggestion from Councillor Heselgrave already, which is, and I don't know if he's spoken about this, but he does think, therefore, that Sharon Buckby should be a member of this board, but I don't.
Yes, Chair. I think what that recommendation was getting at really was to have a look at the current membership of the board, which does include Sharon as the Director of Learning, Education and Skills, and to try and incorporate that into here. Not all the membership, because there's been sort of...
So Sharon is already a member?
Of the Children and Families Learners Board?
No, of this board. Sorry, the recommendation was that she should join this board.
Sure.
But, I mean, basically, I suppose, I'm just saying that's what Councillor Heselgrave suggested yesterday. Who knows whether that's appropriate or whether Sharon wants to join another board. I think that is quite a serious suggestion from Paul, though, so as a Cabinet Member needs to be looked at seriously. I suppose my point is, that's a recommendation, so where is this review going to happen? Is this something that somebody is going to take as an action and bring back, or...?
Yeah, Chair. So what I was thinking was myself and Alison will take a look at the membership, which isn't a huge membership, and then have a look at what would be sensible as key representatives, so we don't make the board too big here, but in terms of key members in line with the terms of reference of the Health and Wellbeing Board, that would be sensible to incorporate. But I hear what you're saying in relation to Sharon Buckby, the Director of Learning Education and Skills.
Thank you. Thanks, and thank you for that, Alison and Gamal. I mean, I think I know Sue-Ann's here today. Thank you for coming, Sue-Ann. And I think we have it, and it's good to have. It will be good to have more voices, I think, from the children's and young people's side of things, because whilst absolutely we know the sort of adult side of the population, etc., is very important. I think, I don't know, just off the top of my head, without having analysed this greatly, I think we do tend to have a bit more of an older population emphasis, perhaps, in the room. Maybe that's I don't know. But anyway, I think more voices coming from the children's and young people's side, more thoughts about what they need, what their representation could be, their health, their well-being, their position, what the system is doing for them, I personally think would be welcome anyway. So that's a good thing. So we're all happy with that report, yes? Right, final item then, and we can finish early. Thank you very much, everyone. Thank you, Gamal. Is the Health and Wellbeing Forward Plan from Alison.
Thank you, Chair, and not going to go through it is for information, but it just sets out kind of the provisional agenda for both the next meeting and the one following it. And I had provisionally put on kind of a priority update from the Child and Family Learners Board at the next session. So I'll touch base with you, Gamal, in terms of what that might look like. So notwithstanding kind of the items that we've raised today, which I'll put on the forward plan. So just to note, and if there are any items that anybody would want to wish to put forward on the forward plan, as always, just let me know. And on the within the item as well, we've just got the deadline for the reports as well for those two meetings. So nothing further for me, Chair.
Thank you, Alison. Councillor, thank you for that. Councillor Kerr.
Just in terms of timing, I think there will be another Health and Wellbeing Board will happen before our next full council meeting. And it'll be the next full council meeting that consider the new membership of the board. So my feeling is that I don't know at which point the Learners Board was going to be disbanded. But if that's at the start of September, we may want to invite potential additional members to come as observer members before the formal change goes through. Could that be considered, Chair, and you consulted on that and make sure it's all going to work?
Yeah, I think that's a good point, Councillor Kerr. I think there is provision within the existing terms of reference to enable us to bring in kind of with the members in an advisory capacity. So even if they're not full members at that next board, we'll be able to get them in, but we'll make sure as well that we put that through in terms of the full council.
Thank you for that, Lucy. It's a typical kind of detailed point from you that's very helpful, that it wouldn't have occurred to me because I don't have at the top of my head those sorts of dates. So that's a really helpful point. Thank you. And we will do that. We're not inundated with people on this board, I don't think. And all contributions are really welcome. So we'll do that as you suggest. Okay, with that, unless there are no further comments, thank you all for coming, and we'll see you all in 2 months' time. Thank you.